again, YouTube family. It's me again, your friend Maxwell-Nery. Today I am sharing more of my notes with you, and I do hope this helps someone out there. One of the ways in which we can encourage ourselves is to find way to reteach the information we are learning. This will help to reinforce memory and just retain the material. Wishing you all much luck on your journey, and feel free to share some of your studying approach with me as well. You could leave me a message underneath the videos, and I'll be sure to read them and take some tips from you as well. But this is my notes, my approach, and I'm hoping it's become beneficial to someone out there. Feel free to like and subscribe. It's free. Subscription just allow you to know when I post new videos, so you can keep in track with my notes and so on. Thank you again for your time. So today we're going to look at blood transfusion procedures and nursing responsibilities. There is quite more than just that into this slides. It's about 52 slides, and I'm just going to take them into chunks. So transfusion equipment, infusion control, and pumps. So it's very important to note compatibility with opaque solution. Transfusion pump controllers may not detect air or monitor flow properly when used with opaque solutions. So like examples include lipid emulsions, blood products. Use only compatible equipments when you are doing transfusion. Risk of hemolysis. Mechanical infusion pump can increase shear stress on red blood cells, leading to hemolysis. The risk increases with high pressure or small bore tubing. So manufacturer guidelines include always follow the manufacturer instruction for approved pump setting and compatibility with blood products. Each device may have unique specification. Manual pressure cuff usage. Manual pressure cuff usage can be used with caution to aid blood flow if gravity is insufficient, but must be monitored to prevent excessive pressure. Then avoid the sphygmomanometer cuffs. Do not use this to infuse blood. They can exert uncontrolled or excessive pressure, increasing the risk of hemolysis and line rupture. So definitely utilize caution and do not use the sphygmomanometer to infuse. Let's talk about blood warmers. Just an overview. Blood warmers are used to safely warm blood products or IV fluid before transfusion to prevent hypothermia, especially in surgical, trauma, or critical care setting. Preventing hemothermia. Rapid infusion of cold blood can lower core body temperature, leading to cardiac arrhythmia, coagulopathy, or impaired clotting, increased risk of infection. Using a blood warmer maintain normothermia and support hemodynamic stability. Use only approved warmers. Only use medical grade manufactured approved blood warming devices. Designed specifically for warming blood products. These devices have precise temperature control, typically 37 degrees Celsius, to avoid damaging blood cells or protein. Avoid usage warming method. Do not use unapproved methods such as microwave. Never put anything in the microwave, most especially with blood. Hot water, bath, do not do that. Electric blanket or heating pads. We do not do that. These can cause hemolysis, uneven heating, and loss of blood product integrity. When to use blood warmers. Recommend in situations such as large volume transfusion, pediatric or elderly patient, hyperthermic patients, massive transfusion protocols. Best practice for nurses is to always verify that the blood warmer is certified for use with blood products. Monitor the temperature setting during use, and check for alarm function and safety features on the warming devices. And then educate the team or your team about risk of improper warming and the damages that can cause to the patient and the products. And just to reinforce again, blood warmers prevent hyperthermia. Blood warmers are used to prevent hyperthermia and adverse reaction during multiple blood unit transfusion. Use approved warmers only. Only specific tested and approved blood warmers should be used to ensure safety and effectiveness. Avoid unsafe warming method, okay? And those include the microwave oven, hot water bath, electric blanket, or heating pads, because these can cause hemolysis as well as uneven heating and loss of the blood product integrity. Client teaching before transfusion. Informed consent. Ensure the patient understands the reason for the transfusion. Discuss the benefit, risk, and alternative. Obtain written consent per facility policy before transfusion. Next, we want to educate about the infection risk. Explain that blood is carefully screened, but there is still a very low risk of infection. Example, HIV, hepatitis B and C. Reassure patient that modern testing methods make this risk extremely rare. Explain the transfusion process. Describe how the transfusion will be given. Example, IV line and the duration. Inform that vital signs will be monitored before, during, and after. Let them know a nurse will be present for close observation at the start of the transfusion. Teach them symptoms to watch for. Teach the patient to immediately report any of the following, such as chills or fever, back or chest pain, nausea or vomiting, shortness of breath, flushing, itching, or rash, rapid heartbeat such as tachycardia, dark urine or a sense of feeling unwell. Emphasize reporting symptoms immediately. Advise the patient to alert the nurse at first signs of any discomfort. Early reporting helps prevent severe transfusion reaction. Reinforce that no symptom is too small to mention. Some nursing consideration for us: documentation of reaction. As nurses, we should document any symptoms and the time of the onset. We want to note action taken, such as stopping the transfusion or notifying the provider. Record vital signs and patient response. Fill out the institution's specific transfusion reaction form. Send the blood bag and tubing to the lab if required for further analysis. So, blood transfusion reaction, immediate action for us to take in this process. Stop the transfusion immediately at the first sign of a reaction. Example, fever, chills, rash, dyspnea, hypotension. This helps prevent the patient from receiving more of the incompatible or contaminated blood. Do not simply just slow the rate. It must be completely stopped. Assessment. We want to take vital signs promptly. Quickly assess the patient condition, the temperature, blood pressure, heart rate, respiratory rate, oxygen saturation. Compare with baseline to evaluate the severity of the reaction. Assess for other symptoms, rash, dyspnea, back pain, anxiety. If IV management, clamp the IV line immediately to stop further blood product entry. Disconnect the blood tubing from the IV catheter hub. Do not leave residual blood infused. Maintain IV access by connecting new tubing and infusing normal saline using a new set, if directed by the provider. Blood bag handling. Return the blood bag and the administration set, tubing, and all material used to the blood bank. This allows for proper analysis and identification of the reaction cause. Example, hemolysis, any contamination or mismatched blood. Follow your institution protocol for documentation and transport. Do not flush the tubing. As I mentioned, do not flush the existing IV tubing with saline. Doing so may push more blood into the patient, worsening the reaction. Always use new IV tubing if IV access must be maintained. Per facility protocol and MD order, you want to notify the healthcare provider immediately. Administer medication as ordered if needed. For example, antihistamine, corticosteroid, antipyretic. Monitor the patient closely for deterioration in her or his condition, and document the entire event accurately. Management of specific transfusion reaction. Positioning, circulatory overload. Transfusion associated circulatory overload, otherwise referred to as TACO. Signs include dyspnea, hypertension, tachycardia, crackles on auscultation, jugular vein distension. Action: elevate the head of the bed, such as high Fowler position. This reduces pulmonary congestion. Administer oxygen as needed. Anticipate administration of diuretic, for example, furosemide, per provider order. Slow or stop transfusion as appropriate. Sepsis management. Contaminated blood product. Signs: rapid onset of chills, high fever, hypotension, and shock. Action to take: stop the transfusion immediately. Maintain IV access with new tubing and saline. Obtain blood culture from the patient and transfusion unit. Administer broad spectrum antibiotic like the fluoroquinolones, for example, as ordered. Monitor for signs of septic shock. Example, decreased perfusion, altered mental status. Supportive care, fluid and oxygen, vasopressors if required. Pharmacologic collaboration. So pharmacologic collaboration. Collaborate with the healthcare provider to administer medication depending on the type of reaction. Antipyretic, such as acetaminophen, for fever or non-hemolytic reaction. Antihistamine, example, dihydrogenone or Benadryl for allergic reaction, and then corticosteroids for severe reaction or anaphylaxis, and then diuretic for those toco reactions, epinephrine for anaphylactic reaction. Record medication given, dosage, and patient response in the medical record. Monitoring blood parameters. Monitor key labs and parameters based on the suspected reaction. Hemoglobin or hematocrit for hemolysis or bleeding. Serum bilirubin levels, LDH, and hepatoglobin for hemolytic reaction confirmation. Renal function, BUN and creatinine, for example, for signs of kidney damage. Coagulation profiles such as PT, INR, APTT. If DIC is suspected. Blood cultures for suspected sepsis. BNP or chest x-ray for circulatory overload. And then documentation and reporting. Want to complete the transfusion reaction reporting form per institution policy. We want to accurately document patients' baseline and post-reaction vital signs, time and nature of the symptoms, intervention performed, and medication given. We want to provide notification and respond, or provide a notification and respond. Submit blood bag administration set and remaining blood to the blood bank for analysis. Continue to monitor and document the patient's status frequently until stable. General precaution in blood transfusion. So first, avoid cardiac dysrhythmia. Rapid infusion of cold refrigerated blood, especially through a central venous catheter, can cause cardiac dysrhythmia or arrest. Some precaution. Warm blood using an approved blood warmer if rapid infusion is needed. Monitor heart rhythm during transfusion, particularly in vulnerable population, example, cardiac patient and pediatric patient. Use only normal saline or 0.9% normal saline. Why? Normal saline is compatible with blood product. Avoid using dextrose solution or lactate ringers, as they can cause hemolysis or clotting. Flush line with saline before and after transfusion to maintain patency. Maximum infusion time. Infusion time for 1 unit should not exceed 4 hours. Why? Prolonged infusion increases the risk of bacterial contamination and septicemia. Discard any blood not transfused within this window. Change the administration set. Change blood administration set at least every 4 hours or after 2 units, whichever comes first. Why? Reduce risk of infection and ensure tubing integrity. Check the administration and inspect the bag. So you want to check expiration and inspect the bag before transfusion. This helps to verify expiration date of the blood product. You want to inspect the bag for leaks, clots, discoloration, particulate matters, or abnormal consistency. Do not use blood with any visible abnormalities. Administer within 30 minutes of release from the blood bank. Blood must be started within 30 minutes or removal from the blood bank refrigerator. So within 30 minutes of receiving the blood, it must start the infusion within that time frame. Because room temperature increases the risk of bacterial growth if not used properly. So you don't want to have it sitting or delayed, because then this is going to increase bacterial growth. If it's delayed, we want to return the blood to the blood bank immediately. So just some key summaries of the time frame. As I mentioned before, time limit start transfusion after using within 30 minutes is the max infusion time per 4 unit of per 4 hours. Change administration set every 4 hours. So the maximum start time after retrieving the blood from the blood bank after taking it off the refrigerator is 30 minutes. And then the maximum infusion time per unit is 4 hours. And you want to change the administration set every 4 hours as well. So recommended infusion rate and monitoring. Infusion rates depend on component and clinical status. The rate of blood transfusion varies depending on the type of blood product. So for example, red blood cells, platelet, and plasma. The patient age, weight, cardiac status, and comorbidities as well. We want to start slowly, for example, 1 to 2 ml per minute during the first 15 minutes to detect any reaction early. Then we want to adjust the rate per protocol. Rapid infusion for low red blood cell components. Blood products with few or no red blood cells, such as platelet, when infused rapidly over 15 to 30 minutes per unit. And then fresh frozen plasma, infuse this over 15 to 30 minutes, depending on volume and tolerance. These are less likely to cause hemolytic reaction, but still require monitoring, of course. Prevent circulatory overload. Transfusion-associated circulatory overload, TACO, abbreviation, risk increase with high infusion volume or rates. Pre-existing cardiac or renal condition, we can see increased risk for TACO or transfusion-associated overload. To prevent overload, we want to infuse packed red blood slowly, as I mentioned before, typically over 2 to 4 hours per unit. We want to also use diuretic, example, furosemide between unit in the high-risk patient as prescribed, and then monitor for signs of dyspnea, crackles, hypertension, jugular vein distension. These are signs of transfusion-associated circulatory overload. Vital signs and lung sound monitoring. We want to monitor timing, baseline assessment immediately. So monitor. So that's what we do: baseline assessment, and want to do before and after transfusion. So early reaction check is 15 minutes after starting transfusion, and then ongoing monitoring every hour during transfusion. And then post-transfusion monitoring continues for at least 1 hour after completion, including in assessment. You want to include the temperature, you want to include the heart rate, respiratory rate, BP, O2 or oxygen saturation, lung sounds. And then we want to document immediately and report any changes in these baselines. Fever, note any fever, tachycardia, hypotension, dyspnea, or adventitious lung sound. And then some key reminder for us. We want to, again, and I'm going to continue to repeat this, for reinforcement. Never exceed 4-hour total infusion time for any blood product. Never exceed 4 hours total infusion time for any blood product. Want to adjust the rate per provider order or unit protocol and patient tolerance. Always monitor more frequently. most especially in like the pediatric patients, elderly, and patient with cardiac compromised conditions. We want to monitor these patients more frequently because they're at a higher rate risk for transfusion associated circulatory overload. These are like this increases their risk, so we definitely want to monitor more frequently in this particular population. Nursing responsibility, just summary. Again, repetitiveness sometimes help with reinforcement. So consent, we want to uptake consent beforehand. So ensure informed consent is obtained and documented before starting the transfusion. We want to confirm the patient understanding of the risk, benefit, and signs of transfusion reaction. We also want to ensure equipment guidelines. We want to use appropriate blood administration set with inline filters. We want to prime tubing with normal saline only, not dextrose or lactate ringer, normal saline only. Have a functional infusion pump or a gravity set ready based on the protocol. We want to monitor for transfusion reaction. We want to monitor for early signs of reaction, including fever, chills, rash, dyspnea, back pain, etc. We want to check vital signs before starting the transfusion at 15 minutes, hourly during the transfusion, 1 hour post transfusion, and then any immediate reaction, want to respond immediately by stopping the transfusion if any reaction is suspected at that time. And then we do not want to flush the line with blood or saline. We want to disconnect the IV tubing at the catheter hub to prevent further infusion. We want to maintain IV access with new tubing and saline. And then we want to immediately notify the provider and follow the facility reaction protocol. Storage and handling, start transfusion. We want to, after receiving the blood product, we want to start transfusion within 30 minutes of receiving the blood from the blood bank. We want to inspect the bag for any leaks, clot, discoloration, or expiration. And of course, we want to infuse the unit within 4 hours maximum to prevent contamination. We want to return unused blood promptly back to the blood bank if it's not administered. And we want to do our documentation and collaboration. We document start and end time of the transfusion. We document vital signs, symptoms, and interventions that is taken. Want to document any adverse reaction and any action taken to address these adverse reactions. Want to also complete a transfusion reaction form per the facility protocol. We want to also collaborate with healthcare team, example the physician, lab, pharmacy, etc. For any diagnostic tests, medication, and also ongoing management. On the next slide, we're going to do some NCLEX questions and strategies. This is just some fun ways also of continuous reinforcement. So as I mentioned, we're going to do some NCLEX question strategies. So it says critical thinking and decision making. NCLEX question tests critical thinking and clinical decision making through scenarios that require application of medical knowledge. Practice with sample questions. Practice with sample questions is crucial to understanding the NCLEX format and complexity, helping to prepare effectively. Patient safety and prioritization. NCLEX questions often focus on patient safety and prioritization, emphasize the importance of these themes in clinical setting. And then effective time management, of course. Effective time management during NCLEX tests is essential to ensure all questions are answered within the allotted time. So here we have 2 NCLEX questions. First question is question 1. Infusion device safety. Which statement about infusion pump used for blood transfusion is correct? So the question is, Which statement about infusion pump used for blood transfusion is correct? And we have our choices here. Infusion pumps are always safe for administering blood product. Only use infusion pump if they are approved for opaque fluid. Any IV pump can be used as long as the rate is slow. Infusion pump must be used with a pressure cuff at 500 millimeter per mercury. And remember, we went through this one in our notes, and the correct answer is B. Only use infusion pump if they are approved for opaque fluid. And the rationale: infusion pump must be compatible with blood product. Those not approved for opaque solution may cause hemolysis due to negative pressure. So question 2, address blood warmer safety. The question is, a nurse is preparing to administer several units of refrigerated blood to prevent hyperthermia. The nurse should: A. Warm the blood in microwave. Use hot tap water to warm the bag. Use only an approved blood warmer device. Let the blood sit at room temperature for 1 hour. And we know the answer is C. We only use an approved blood warmer device. The rationale: only special warmer tested and approved for blood products should be used. Microwave and hot water are unsafe and can damage blood cells. So question 3 and 4. Question 3 is recognizing circulatory overload. Taco. Which signs indicate circulatory overload during a transfusion? A. Chills and flushing. B. Cough, shortness of breath, and distended neck vein. Nausea, vomiting, and diarrhea. Pallor, cyanosis, and muscle ache. We know the correct answer is B, as coughing, shortness of breath, and distended neck vein indicates circulatory overload. The rationale: these are classic signs of circulatory overload. Other signs may include hypertension, tachycardia, and crackles. Question 4 is focusing on transfusion reaction intervention. The question is, a client developed chills and tachycardia during a transfusion. What is the nurse's first action? And our choices are: decrease infusion rate, notify the provider, stop the transfusion and take vital signs, administer acetaminophen. So we know the first action is to stop the transfusion and take the vital signs. The rationale, as I mentioned in my note, immediate action in a suspected transfusion reaction is to stop the transfusion and assess the client. So question 5, and I believe I have 10 of these questions. So question 5 and 6. Question 5 is blood product handling. What should a nurse do if blood is not administered within 30 minutes of leaving the blood bank? So restore it in the unit's medication refrigerator. We return it to the blood bank. Start the transfusion anyway. Warm it using the tap water. And we know the correct answer is to return it to the blood bank. If it's not infused within 30 minutes, we return it to the blood bank. The rationale: blood must be administered within 30 minutes or returned to ensure safe temperature regulation and reduce bacterial growth. And then question 6 says sepsis recognition. Which symptom is most concerning for sepsis during a blood transfusion? A. Flushing and headache. Vomiting, diarrhea, and hypotension. Chills and mild fever. Fatigue and pallor. And we know vomiting, diarrhea, and hypotension. or most concerning for sepsis during a blood transfusion. And these are signs of septic transfusion reaction, which is a medical emergency requiring blood culture and treatment. So we're going to see vomiting, diarrhea, and hypotension. Next questions. We have question 7 and question 8. Question 7, appropriate infusion rate. And which blood product may be safely infused more rapidly in most clients? Is that whole blood, platelet, red blood cells, packed red blood cells, platelets, and cryoprecipitate? Correct answer is C, platelets. Rationale: platelets contain few red blood cells and are generally infused over 15 to 30 minutes, although the nurse must still monitor for fluid overload. So platelets is our answer. We can safely infuse more rapidly in most clients, and that's over 15 to 30 minutes, but we must still monitor for fluid overload. Question 8, contraindicated equipment. Which device should not be used to increase the flow rate of a blood transfusion? I think we all should know this one. Special manual pressure cuff, max 30 mm per mercury, blood compatible infusion pump, blood warmer. Remember, the question says which device should not be used, and then sphygmomanometer cuff, and we know it's D. I mentioned that earlier. Sphygmomanometer cuff should not be used to increase the flow rate of blood transfusion. These cuffs do not apply uniform pressure and can cause hemolysis or bag rupture. So we do not use a sphygmomanometer cuff to increase the flow rate of a blood transfusion. And question 9 and 10. So question 9 is client teaching. Which client statement indicate the need for further teaching about blood transfusion? A, I should report any back pain or chills during the transfusion. B, the transfusion might take up to 4 hours. And C, if I get a fever later, I don't need to tell the nurse. And D, I might need to sign a consent form before getting before getting blood. And the question is, which statement indicate the need for further teaching about blood transfusion? So we know we're looking for the wrong answer. And should they be reporting if they get a fever later? They should report it. So we know that C is the correct answer. If I get a fever later, I do want to report. It says do not need to tell the nurse. They do need to tell the nurse. So C is the one we're looking for. Fever can be a sign of delayed transfusion reaction or sepsis and should always be reported. And then our final question for reinforcement in teaching is transfusion compatibility and safety. Before initiating a blood transfusion, which action is essential for safety? So check blood glucose level, administer all IV medication first, inspect the blood bag for a leak or clots, start the transfusion at a rapid rate. So the correct answer is C. We want to inspect the blood bag for leak or clots. So it said, before initiating blood transfusion, which action is essential for safety? We want to inspect the blood bag for leak or clots. The rationale: the nurse must assess the blood bag for integrity, color, and presence of clots or air to ensure it is safe for transfusion. So those are my 10 questions. We're going to move into the next category, which is blood. Let me just pull it up. Blood bank precaution and nursing responsibility. Okay, blood bank precaution and nursing responsibility. Reinforcement, reinforcement, reinforcement. So, blood bank precaution. Key safety protocol. Authorized personnel only we're going to address first. So, access to the blood bank is restricted to trained and authorized healthcare professionals. This ensures proper handling of blood products, adherence to identification, storage, and transport protocol, prevention of mishandling or contamination, recipient identification process. Correct patient identification is critical to prevent fatal transfusion error. These processes include matching patient's full name, date of birth, and their unique identified number. Verifying blood unit label and cross-match documentation against patient wristband and the order. We want to use of 2 licensed professionals or electronic verification to confirm identity before the administration of any blood product. So single client transport policy. Blood products must be transported for only one client at a time. Why does this matter? It prevents misdelivering or mix-up between patients. It also ensures the right product reaches to the correct recipient. And also maintain traceability and accountability. So, just some additional handling notes that I have is blood products should be transported in a temperature control condition if required, and then transfusion must be initiated within 30 minutes. We're going to pass that test very well, okay? of when it's issued to maintain product integrity. Any unused blood must be returned to the blood bank immediately, and do not store in the nursing unit or the nurse's refrigerator. It's a special way to store the blood. So if we're not using it or infusing within those 30 minutes, we want to return that blood back to the blood bank. So client identification and compatibility verifications. We want to verify physician prescription and client identity before collecting blood or initiating any transfusion. Confirm there is a valid physician order for the blood product. Check type of blood product ordered. Example, is it packed red blood cells or platelets, whole blood? You want to check volume and rate to be infused. Any pre-medication that is required. You want to check all these things. Ensure all orders are current, complete, and properly documented. Client identity confirmation at the bedside. Okay. Immediately before transfusion, verify client identity using 2 licensed professional nurses per your institution policy. Use 2 identifiers, the patient's full name, date of birth, or hospital ID number. Match the client wristband to the blood unit label, the cross-match tag, the requisition or transfusion form. This is a critical safety checkpoint. Never bypass or rush identifying verification. Compatibility check of products, of blood product. Check the ABO and RH compatibility of the donor blood with the recipient. Ensure the blood bag tag, unit label, and requisition form all matches the client. ABO group A, B, or O. RH type, whether it's positive or negative. Then Confirm. Donor unit number match the cross-match record. Blood product has not expired. Must check the expiration date. There are no signs of damage as mentioned, clots, leak, discoloration. Use institutional or electronic verification system. Example, barcode scanner, where it is applicable. And then some final checks before transfusion, as I mentioned before. Repeat for additional reinforcement. Verify the physician order, the product, the volume, the rate, and any pre-medication that may be needed. You want to identify the client by full name, date of birth, or hospital ID. You want to check the blood bag label for the type, cross-match ABO, RH, positive or negative. The unit number and expiration. You want to cross-match and requisition form, match the blood and bag and patient. And check, do some bedside check. And this is done by 2 professional nurses. Just to verify, you want to do all the checks and confirmation beforehand. Client assessment before transfusion. Assess cultural and religious beliefs. Determine if the client has cultural, spiritual, or religious belief that may affect blood acceptance. Example, Jehovah's Witness. You want to offer alternative when appropriate. Examples we went over in one previous slide. Autologous transfusion, bloodless machine medicine technique. And then we want to respect the patient autonomy and involve the ethics or spiritual care team if needed. Informed consent. We want to confirm. Ensure the client or legal representative has received information about the risk, benefit, and alternative. Sign a valid consent form specific to blood transfusion. We want to reaffirm understanding and any answers and any last minute questions. We want to address those. We want to also check their transfusion history. We want to review the client previous transfusion histories, any past reaction to help us in advance. Example, if they had febrile reaction, allergic, hemolytic, and so on. Use any pre-medication that we may need to utilize in advance. Example, acetaminophen or dihydroamine, Benadryl. Inform the provider if there is a history of complication to adjust the care plan. And then assess and monitor vital signs and notify physician, right? So we want to record baseline vital signs immediately before starting the transfusion. These include their temperature, blood pressure, heart rate, respiratory rate, oxygen saturation. There's some critical points for us as well. If the patient has a fever, typically that is greater than 100.4 or 38 degrees Celsius, we want to notify the physician before we start before we start the transfusion. And this is because fever can mask early signs of transfusion reaction and may delay the transfusion. So until further, and then they may delay the transfusion until further evaluation. So at this point, we may want to do additional evaluation. If there is a fever that is greater than 100.4, and notify the physician before we start it so that they can check and do any additional evaluation that might be needed beforehand. So administering a blood transfusion. This is just summary guideline. So volume consideration, prevent circulatory overload, be cautious in as I mentioned earlier, the elderly and the pediatric population, people with renal disorders, or renal failure, or cardiac patients. Usual volume for 1 unit of packed red blood cells is 250 to 300 ml. We want to infuse over 2 to 4 hours to avoid volume overload or transfusion reaction overload, circulatory overload. May require diuretic between units, example furosemide as prescribed, and then pre-medication if needed with dihydramide, Benadryl. Given 30 minutes before transfusion if ordered, or history of reaction. Want to give it 30 minutes before transfusion is ordered, or if there's a history of reaction, want to give it Tylenol, acetaminophen to reduce risk of febrile reaction, diphenhydramine to prevent mild allergic reaction, then hydrocortisone for pain with prior moderate severe reaction, and monitor and manage the transfusion. Some time points before transfusion, as I mentioned, take baseline vital signs, confirm ID, consented sign, cross-match, and compatibility. Start of transfusion begins slowly, usually between 1 to 2 ml per minute for the first 50 minutes. Approximately 25 to 50 ml for first 15 minutes, most critical period. So observe closely for fever, chills, hives, shortness of breath, back pain. And then during the transfusion, we're going to monitor vital signs every hour or per your facility protocol. Watch for symptoms after transfusion. Monitor and document vital signs for 1 hour post the transfusion. So if an adverse reaction occurs, as I mentioned before, we want to stop the transfusion immediately, and also disconnect the blood tubing at the catheter hub, and don't flush the line. Maintain IV access with new tubing and normal saline. Then we want to immediately notify the provider and follow reaction protocol. So some benefit of blood transfusion: improve oxygen carrying capacity in anemia or hemorrhage, support clotting such as plasma platelet for incoagulatory, and then increase platelet count as well in thrombocytopenia. Can be life-saving in trauma, surgery, or critically ill patients. And then just some summary takeaway for safe transfusion essential. Volume control, slow infusion over 2 to 4 hours, diuretic PRN where is needed, pre-medication for patient with prior mild to moderate reaction. As I mentioned, start slow, first 15 minutes most critical, monitor closely. Monitoring vital signs, so do you want to do a baseline vital signs, and then hourly and post follow-up 1 hour. And then adverse reaction protocol, of course we want to stop the infusion immediately, want to disconnect the tubing at the hub and notify the provider immediately, want to put a new tubing and flush the line with normal saline. So monitoring and documentation during transfusion. Monitoring for transfusion reaction, closely observe the client during the transfusion, especially the first 15 minutes for any signs of reaction. Immediate reporting of unusual symptom is critical. And then document client tolerance. Accurately record the client response throughout the transfusion to ensure any reactions or complication are noted, and treatment effectiveness of evaluation is also very important when you're documenting all these, what you're doing. So now we look at transfusion reaction signs and symptoms, and we went over these already, but we do them again. So transfusion reaction signs and symptoms. Immediate transfusion reaction occur during or within minutes to hours after transfusion begin. Reaction type, common signs and symptoms: febrile, non-hemolytic, fever, chills, headache, and flush. Allergic or allergy, mild to moderate, urticaria such as hive, itching, and rash. Acute hemolytic is severe, fever, chills, chest, back pain, hypotension, sometimes dark urine, hemoglobin in the urine. Anaphylactic, you're going to see dyspnea, hypotension, wheezing, angioedema, chest tightness. And then for septic, due to contaminated blood, a rapid fever, chills, hypotension, shock. And then circulatory overload, you're going to see dyspnea, hypertension, crackles, distended neck veins. And then lung injuries, severe hypoxia, bilateral pulmonary infiltrate, and fever. Sometimes delayed transfusion reaction can occur. This typically days to week after the transfusion. So some reaction type common delayed signs and symptoms include delayed hemolytic reaction, low-grade fever, mild jaundice, drop in hemoglobin, and fatigue. And then the graft versus host disease. It's rare, but it's a very fatal. So you see fever, rash, diarrhea, liver dysfunction, and pancytopenia. And then some post-transfusion purpura, thrombocytopenia, bruising, bleeding. 5 to 12 days post-transfusion typical. Iron overload, chronic transfusions such fatigue, joint pain, liver dysfunction, and cardiac symptoms. And there's some key reminders. Always monitor closely for immediate reaction during the first 15 minutes. Delayed reaction may require follow-up labs, example bilirubin, CBC, hematocrit, and hemoglobin. And we want to document and report all suspected reaction per facility protocol. So emergency intervention for transfusion reaction. Immediate action is to stop the transfusion. Stop the transfusion immediately at the first signs of any reaction: fever, chill, rash, dyspnea, back pain, hypotension. Do not flush the line with saline. Disconnect the blood tubing at the IV hub. Maintain IV access with new tubing and 0.9% normal saline to keep the line open. Monitor the patient closely. Take and document vital signs: BP, heart rate, respiratory rate, O2 sat, and temperature. Respiratory status, example lung sounds and any effort. Mental status, confusion or restlessness. Monitor for worsening in symptoms such as hypotension, tachycardia, respiratory distress, or hypoxia, flushing, urticaria, hematuria. Notify appropriate personnel. Immediately notify the physician or the provider. Inform the blood bank that a transfusion reaction has occurred and follow your facility transfusion reaction protocol. Preserve and send blood product back to the blood bank. Save the blood bank and administration set. Do not discard. Send it back to the blood bank. Patient blood samples. Follow hospital protocol for returning to the blood bank. Lab for testing. Administer medication as ordered, such as antihistamine or diphenhydramine for allergic reaction. Antipyretic, such as acetaminophen for fever. Corticosteroids for more severe immune reaction. Epinephrine and oxygen for anaphylaxis. IV fluid and vasopressors for hypotension and shock. And then we want to document thoroughly the time the symptom began, any vital signs and symptoms observed, action taken, notification and provider order, complete transfusion reaction report form per your facility or hospital protocol. Next, we're going to do some NCLEX time questions. Again, we have 10 questions to go through. So question 1, it says identity and compatibility. Which action is a nurse's highest priority before starting a blood transfusion? Is it asking the client if they have heating? Is it verifying the expiration date on the IV fluid? Is it confirming product compatibility and client identity? Is it checking IV site for infiltration? And it says, which action is the nurse's highest priority before starting the blood transfusion? And it is confirming products compatibility and client identity. And the rationale says verifying the client identity and confirming blood products compatibility are the most critical safety steps to prevent transfusion reaction and ensure the right client receive the right blood. Question 3, cultural consideration. A client who is a Jehovah's Witness is scheduled for surgery and may require blood. What should the nurse do first? Inform the client that blood transfusions are routine. Request the client to sign a consent form for blood. Notify the provider of the client's religious belief. Encourage the client to reconsider their decision. And we know we are going to notify the provider of the client's religious belief. It is essential to respect clients' autonomy and beliefs. The healthcare provider must be informed to explore alternative treatment options that align with the client's faith. And then question 2, transfusion reaction. A client is receiving a blood transfusion, begins to report back pain and chills. What is nurse priority action? And we already know, but administer acetaminophen or slow the transfusion rate or stop the transfusion and keep the IV line open with normal saline. Notify the physician after the transfusion is complete. We are going to stop the transfusion, keep the IV line open with normal saline. These are signs of possible transfusion reaction. The nurse must stop the transfusion immediately and maintain IV access with normal saline to manage any adverse reaction. So I'm going to go on to question 4 and 5. Informed consent. Before initiating a blood transfusion, what legal responsibility must the nurse ensure has been fulfilled? The client has been fasted, the IV site is patent, informed consent has been obtained, the nurse has complete blood bank training. The correct answer is C. Informed consent has been obtained. Before initiating a blood transfusion, we must ensure informed consent has been obtained. The client must be informed about the benefit, risk, and alternative to a blood transfusion and must provide voluntary consent. Question 5. Initial monitoring. How long should the nurse stay with the client after starting the transfusion? 5 minutes, 10 minutes, 15 minutes, or 30 minutes? And the correct answer is C. Correct answer is 15 minutes. Rationale: the first 15 minutes are the most critical, as most severe transfusion reactions occur during this period. The nurse must stay with the client and monitor closely. So, question 6 and 7. Question 6, delay reaction signs. Which of the following is a sign of the delayed transfusion reaction? A, chills and diaphoresis. B, mild jaundice. Back pain. Rapid thready pulse. And we are looking for delayed transfusion reaction. Correct answer is B, mild jaundice. Jaundice may occur days after a transfusion due to hemolysis of transfused red blood cells and is a hallmark of a delayed transfusion. So the answer here is mild jaundice for delayed transfusion reaction. So question 7, emergency transfusion. In an emergency, which type of blood can be administered to most clients without prior serologic testing? Is it AB positive? Is it O negative, B positive, or A negative? And the correct answer is O negative. Choice B. O negative blood is considered a universal donor for red blood cells and can be safely given in emergency when blood typing is not available. So this is question 8 and 9. What should a nurse do if blood has not been administered within 30 minutes of recipient from the blood bank? We went over this one before. Store it in the unit medication refrigerator. Begin the transfusion immediately. Return the blood to the blood bank. Document the delay and monitor the blood for safety. Correct answer is C. We want to return that blood back to the blood bank. Blood must be administered within 30 minutes or we return it, as improper storage increases the risk of bacterial growth and hemolysis. So no, we do not want to store it in the unit refrigerator. We want to return it. Then question 9, preventing circulatory overload. What should a nurse check before starting transfusion to help prevent circulatory overload? Are we going to check the blood type, hemoglobin level, blood bag volume, or physician schedule? Correct answer is C. We want to check blood bag volume. Knowing the volume of the blood product helps a nurse plan appropriate rate for infusion, especially in clients at risk for fluid overload, such as our renal patient, our cardiac patient, our pediatric patient, elderly population. We want to make sure. So next question, last question, is question 10, medication administration, and we went through these as well. A client with a history of transfusion reaction is prescribed diphenhydramine IV before transfusion. When should this be administered? Is it 15 minutes after transfusion begin? At the midpoint of the transfusion? Immediately before starting the transfusion? Or 1 hour after the transfusion ends? Correct answer is immediately before starting the transfusion. IV pre-medication should be administered immediately before transfusion to minimize the risk of a reaction and ensure effectiveness. And I understand some places we read it says 30 minutes before, so we get different information at times, but some places say immediately before starting the IV transfusion, some places say 30 minutes before. You want to identify with your facility protocol and provider's instruction. Now we look at total parental nutrition, the clinical uses, monitoring, and nursing care. Total parental nutrition is a method of delivering essential nutrient directly into the bloodstream via a central venous catheter, bypassing the gastrointestinal tract. It is used when patients are unable to ingest, digest, or absorb nutrient adequately through the GI system. TPN, or total parental nutrition solution, contain a mix of dextrose, amino acid, lipid, electrolytes, vitamins, and trace elements tailored to the individual needs. Total parental nutrition, just some clinical overview, monitoring and nursing care. So it's a method of delivering essential nutrient, as I mentioned before, directly into the bloodstream via a central venous catheter, thereby bypassing the gastrointestinal tract. It is used when patients are unable to ingest, as I mentioned before, digest or absorb nutrient adequately to the GI system. is a solution containing, as I mentioned again, a mixture of dextrose, amino acid, lipid, electrolytes, vitamin, and trace elements tailored to the individual need. So some common clinical use for it, indicating patient with non-functional GI tract. For example, if a patient has bowel obstruction, short bowel syndrome, severe Crohn's disease, or paralytic ileus. Severe malnutrition also is a indication, unresponsive to oral or enteral feeding. Major GI surgery in recovery where enteral feeding is not possible or safe for the patient. And then in situation like pancreatitis or fistulas where gut rest is necessary at this point. It's also used in cancer patients undergoing aggressive treatment that therefore contribute to impairing the GI function. Some nursing care, definitely aseptic technique, strict sterile protocol for catheter care to prevent infection. We want to monitor infusion to ensure correct rate and type of the solution using infusion pump. And then check total parental solution. We want to inspect for color, clarity, expiration date, and any separation in the solution. We want to also do daily weights for the patient. This track fluid retention or loss. And then we want to also do blood glucose monitoring. We do this to manage any hyperglycemia or hypoglycemia. And then monitor for complications such as I mentioned before, infection. You might see fever, chills, redness at the catheter site. These are signs of possible infection. Then we monitor metabolic such as their electrolytes and liver function. And then any mechanical, like monitor the catheter site for any occlusion or dislodgement. And then definitely always we do patient teaching. For home patient, we want to teach them about the line care. We want to teach them to recognize complication and when to seek help. Complications such as maybe infection at the site, any signs and symptoms of hypoglycemia. I want to just teach them all the things they need to know so that they can seek help in adequate time. So gonna reiterate a little bit more. Total parental nutrition, as I mentioned in the intro, is a medical method of providing complete nutrition support to a patient intravenously. It does bypass the digestive system entirely and deliver essential nutrients such as carbohydrate, protein, fats or lipid, electrolytes, vitamins, and trace elements directly into the bloodstream through the use of a central venous catheter. And the primary purpose is to maintain or restore nutritional status in individuals who are unable to eat or absorb nutrient adequately through the GI tract. Energy production such as tissue repair and healing is also good for growth and development for those who are we could utilize that as a purpose as well. And then organ function support in the efforts of resting GI system. So as I mentioned before, the primary purpose is basically just to maintain or restore nutritional status in individuals who are unable to eat or absorb nutrient. And I'm going to be repeating a lot again, just for continuous reinforcement. So clinical use and nutritional support of total parental nutrition. is used to deliver complete nutritional support to patients who cannot meet their nutritional need through oral or enteral tube feeding. It plays a vital role in enhancing nutritional status, correcting malnutrition, and supporting recovery in various clinical settings. So enhancing nutritional status provides a balanced mix of essential nutrients tailored to patient individual metabolic need, including carbohydrates such as dextrose for energy, protein like amino acid for tissue repair, immune support and growth, and fats such as lipid for essential fatty acids and calorie dense energy, and then the electrolytes and vitamins and trace elements to support cellular and organ function. The overall goal basically is to improve or maintain body weight, muscle mass, and immune function. Also help with wound healing, especially in patients who are critically ill or unable to feed normally. And as I mentioned, for addressing malnutrition, TPN is particularly important in severely malnourished patients. Example, those with low BMI, muscle wasting, or nutritional deficiency. Patients with anorexia or poor appetite due to chronic illness or cancer, and those with gastrointestinal disease, to prevent adequate absorption of nutrients. And the goal is to prevent complication of nutrition, such as delayed wound healing, infection risk, muscle breakdown, and organ dysfunction. So some additional clinical indication is used a wide range of medical conditions, including, as I mentioned before, gastrointestinal disorder, short bowel syndrome, after bowel resection, severe Crohn's disease or ulcerative colitis, bowel obstruction like mechanical or functional like ileus, paralytic ileus, and then enterocutaneous or gastrointestinal fistula, and then post-surgical patient after major abdominal surgery where enteral feeding is not feasible. We want to promote healing when gut by providing gut rest. Critical illness and ICU patient as well. In patient with multi-organ failure, sepsis, or trauma who cannot tolerate enteral feeding. Enteral feeding. And then cancer patient with severe chemo or radiation induced mucositis, mucositis. We want to utilize this approach as well. And then tumor obstruction in the GI tract is also an indication. Profound anorexia as well. And as I mentioned, with the pancreatitis, just some break it down a little bit, or to go a little bit more in details for those who don't know. It's a severe case when feeding the gut worsens symptoms or pain. It's an inflammation of the pancreas, a gland that is located behind the stomach. That it plays a critical role in both digestion. It is an exocrine. It has exocrine function. And the exocrine function, it's blood sugar regulation, and then endocrine function as well. The condition can be acute, sudden, and short-term, or chronic. In pancreatitis, enzymes become activated within the pancreas itself instead of the small intestine, leading to altered digestion of the pancreas, pancreatic tissue, and then inflammation, and sometimes necrosis of the tissue or death of the tissue can happen in pancreatitis. So in situation like this, they to rest the system or not, because it's not functioning properly, where it's secreting like amylase and the different digestive enzyme. We want to give it a rest, or give the GI system a rest. We use total parenteral nutrition. And then in acute pancreatitis, it's a sudden onset. Often this is reversible with treatment. And then we have chronic pancreatitis. It's long-term inflammation causing permanent damage and loss of function. Complication of pancreatitis on metabolism can lead to multiple metabolic disturbance due to impaired endocrine and exocrine function. Glucose metabolism disturbance, for example, damage to insulin producing beta cells can lead to hyperglycemia and even diabetes mellitus. In some cases, impaired glucagon secretion may cause hypoglycemia. So poor blood sugar control, especially in chronic pancreatitis, and then malabsorption and malnutrition. Chronic pancreatitis impair the secretion of digestive enzyme, leading to poor digestion of fat, protein, and carbohydrate, as I was mentioned before. And then in situations like this, we'll see like cytora, those fatty stools, weight loss, and nutrition deficiency. Protein, energy, malnutrition, and fat-soluble vitamins. Those fat-soluble vitamins are the A, D, E, K deficiencies also possible. We might see electrolyte imbalance as well, stemming from vomiting, poor intake, fluid shift in acute pancreatitis. And this can cause like hypoglycemia, as I mentioned before, hypomagnesemia, hyponatremia, hyponatremia, hypokalemia. And then the effects with these, you're going to see muscle cramp, cardiac arrhythmia due to the hypokalemia, and neurological symptoms as well. Then increased metabolic demand is pancreatitis trigger a systemic inflammatory response, especially in the acute severe cases. This can lead to hypometabolic state with increased calorie and protein need for tissue repair and immune response. So high risk of catabolism, muscle breakdown, and nutritional deficit. Lipid metabolism disturbance in some case, especially in hyperlipidemia induced pancreatitis. So you're gonna see like lipid metabolism is directly affected. So it would elevate the triglyceride level and can worsen inflammation. And then in exacerbation of pancreatitis, increased cardiovascular risk as well. So just to kind of like just go over pancreatitis for those who didn't understand what the implication when it comes to total parenteral nutrition. So as I can just do, pancreatitis disrupt both digestion and hormonal function of the pancreas, leading to significant metabolic complication. These include blood sugar imbalance, malnutrition, electrolyte disturbance, and increased metabolic demand. Addressing these issues often through nutritional support like TPN when needed is critical in the management and recovery of pancreatitis patient. So clinical indication of malnutrition. Malnutrition occurs when a patient's or a person's nutrient intake or absorption is inadequate to meet the body need, leading to impaired health and function. It can result from undernutrition, lack of calories, protein, or micronutrition, or disease-related cases. Clinical indication of malnutrition. These are signs and situations that may prompt a clinical suspicion or diagnosis of malnutrition. Unintentional weight loss, like greater than 5% in 1 month or greater than 10% in 6 months. Reduced fat intake or appetite. So chronic illness or acute injury associated with increased metabolic demand. Example, cancer, sepsis, and trauma. And then impaired gastrointestinal function. Example, vomiting, diarrhea, malabsorption. Increased nutrient loss, like wounds and fistula burns. And then physical immobility or frailty. So poor wound healing or frequent infection also. So key laboratory markers of malnutrition, while lab values are not diagnostic alone, they support clinical finding. Markers, possible indication, albumin. So albumin is going to be low. Chronic malnutrition or inflammation, so affected by hydration, stress, not a sensitive acute marker. And then pre-albumin is going to be low. In shorter term changes in protein status, more sensitive to acute malnutrition. The transferrin is going to also be low, reflecting protein depletion or iron status. Total lymphocyte count is also going to be low due to immune suppression, like linked to protein deficiency. Electrolytes like potassium, magnesium, phosphorus is all going to be low, often low in refeeding syndrome or prolonged malnutrition. Hemoglobin and hematocrit is also going to be low, indicating iron, B12, and folate deficiency. And then vitamin and mineral levels like vitamin D, B12, zinc, and iron, they're all going to be low as well. So physical signs of malnutrition in general appearance is the person's going to be thin and a frail body, sunken eye, dry or pale skin. They're going to have muscle wasting as well, loss of muscle mass in temples, shoulders, arm, also in thighs, weak grip strength. Fat loss is going to be sunken cheeks, reduced subcutaneous fat over the rib or triceps. Skin and hair changes, dry flaky skin or poor wound healing. Thin, brittle or spear hair. So the hair is going to be thin and brittle. For edema, swelling in the ankles, legs, or face may mask weight loss. In the oral, it's going to be cracked lips, inflamed tongue like glossitis, bleeding gums due to vitamin C deficiency. And then for neurological, some confusion, irritability, peripheral neuropathy linked to vitamin B deficiency. So some overall conclusion: malnutrition present with a combination of clinical signs, lab abnormalities, and physical finding. Accurate assessment involve holistic approach using nutritional screening tool, medical history, and diet assessment, physical examination, as well as relevant laboratory tests for early identification and intervention. So nursing consideration and restriction. TPN plays a critical role in the safe administration and monitoring of TPN. Because TPN is a complex high-risk therapy, careful attention must be paid to its administration, system management, and medication compatibility. Proper use of the TPN system through central line use. TPN is a typically administered via central line venous catheter, like a PICC line, subclavicle, or internal jugular line. Peripheral administration is only used for short-term, low concentration solution. Of course, aseptic technique is a must. Strict aseptic technique must be used for line care, dressing change, and when handling TPN. Follow hospital infection control protocol to prevent central line associated blood infection, the CLASB. Tubing and filter. Use the dedicated tubing and a 0.22 microgram filter or a 1.2 microgram for lipid containing solution. And then you want to change the TPN tubing every 24 hours to reduce infection risk. For the infusion rate, TPN must be infused using an electronic infusion pump to ensure accurate delivery. Titrate the rate gradually when starting or stopping to avoid hyperglycemia or hypoglycemia. So medication compatibility and restriction. So no medication mixed with TPN. Medication should never be added directly to TPN solution unless prepared by a pharmacy under sterile condition. TPN incompatibility with most IV medication due to risk of precipitation or chemical reaction. No shared IV line. TPN requires dedicated line or lumen. Do not mix with other IV fluid or medication in the same line. If medication must be given concurrently, use a separate lumen or separate IV access. Monitor for incompatibility. If a drug must be administered via the same line, Example, in emergency, verify compatibility using hospital resource or pharmacist where needed. Never administer blood product or antibiotic through a TPN line unless cleared by a clinician or a pharmacist. Nursing monitoring responsibility. You want to monitor blood glucose level. You want to monitor the blood glucose level every 4 to 6 hours initially and adjust insulin as needed. You want to also check electrolytes, renal, and liver function tests regularly as ordered and monitor for signs of infection, such as fever, redness at the site, chills, etc. They want to observe for fluid overload like edema, shortness of breath, weight gain. We want to also check TPN solution integrity for the color, clarity. We want to check for expiration date before hanging it, and then we want to also do daily weight, intake, and output monitoring. Watch for complications like refeeding syndromes, catheter-related infection, and thrombosis. So some special nursing consideration. You want to educate the patient and the family, especially for home TPN patient, on line care, signs of infection, and pump operation. Coordinate with the dietitian, the pharmacist, and physician for adjustment to TPN formula. Discontinue TPN gradually to avoid rebound hypoglycemia. We never want to just abruptly discontinue. And you want to document infusion rate, site condition, and patient response on a regular basis. So just some overall, nurse want to ensure safe and effective use of TPN through proper line care, strict adherence to compatibility guideline, vigilantly monitor and provide patient education, prevent complication like infection and metabolic imbalance requires a team-based approach and strong nursing vigilancy. So baseline data collection before TPN administration. So before initiating total parental nutrition, it is essential to gather comprehensive baseline data to assess the patient nutritional status, identify for potential risk, and establish monitoring plan. This helps to ensure safe initiation, proper dosing, and early detection of any complication. We want to do vital signs assessment, monitor vital signs, provide a baseline to detect adverse reaction or complication during the TPN therapy. So like temperature, monitor for infection, catheter-related bloodstream infection, check the heart rate or pulse. Elevated rate may indicate infection or fluid imbalance. And we want to check respiratory as well. Watch for signs of respiratory distress or fluid overload. Do the blood pressure to assess for hypotension, which will possibly indicate dehydration, or hypertension, which could possibly indicate fluid overload. And then oxygen saturation, the SpO2. We want to elevate for adequate oxygenation, especially in critical ill patient. So we want to evaluate for adequate oxygenation. Make sure that their oxygen saturation is within normal range. And then we want to do weight. So baseline body weight is crucial for calculating nutritional need and tracking fluid retention or loss. So baseline laboratory evaluation include these labs, such as when you do evaluation of labs, help to assess nutritional status as well as organ function and potential electrolyte imbalance. So nutritional and protein status like albumin and pre-albumin, these are indicators of protein status. So albumin is not reliable in acute illness, but these are typical indicators that we look at for protein status. So I want to do look at total protein, electrolytes, sodiums, potassium, chloride. We want to look at calcium and magnesium level as well as phosphorus level. These are critical for identifying risk of refeeding syndrome, especially in malnourished patients. I want to look at renal as well, like the BUN and the creatinine. So urine output for hydration status and renal clearance. And then we'll look at liver function tests, like the the ALT and the AST, ALP and the bilirubin as well. Then we want to check albumin, also reflect liver synthetic function. We want to look at blood glucose, most especially on TPN, fasting blood glucose sugar and random glucose sugar. So important for identifying insulin need and monitoring for hyperglycemia after TPN initiation. Complete blood count, white blood cell count, baseline for detecting infection. Hemoglobin and hematocrit may indicate anemia or blood loss, and then platelet for clotting status. Lipid profile, if lipids are included in TPN, we want to check the lipid profile. The triglyceride must be assessed prior to enduring lipid infusion. Micronutrients and vitamins level, especially in long-term or severely malnourished patients. Iron, zinc, copper, we want to look at those. Vitamin B12, folate, vitamin D, vitamin A, vitamin K, and other pre-TPN assessment. We want to do as much as possible, like looking at the insertion site, check for central line patency, signs of infection, do a chest x-ray to confirm catheter tip placement in the central vein. Nutritional risk screening, want to do dietary history, assessment for fluid balance like edema, ascites, and dehydration. And before starting TPN, we want to do a thorough baseline assessment. Is critical and should include full set of vital signs as mentioned before, weight and fluid balance. We want to do comprehensive lab testing, nutritional markers, electrolyte, organ function, evaluation of vascular access. This function allows for safe TPN initiation and help guide ongoing monitoring to prevent or quickly respond to any type of complication that could be happening around that time. So monitoring during total parental nutrition, as I mentioned on the previous, is ongoing monitoring during this time is essential to ensure patient safety, detect complication early, and adjust the therapy as needed. Nursing and clinical staff should assess metabolic function, infection, mechanical risk throughout the course of the TPN administration. We're going to do blood glucose monitoring every 46 hours initially, and then daily once stable. And this is because TPN contains a high concentration of dextrose, which may cause hyperglycemia or hypoglycemia, especially when stopping the TPN abruptly. So definitely want to monitor the capillary blood glucose and administer insulin as prescribed. So regular insulin can be added to TPN or given subcutaneously. So we also want to taper off TPN gradually to avoid any rebound hypoglycemia. So we want to monitor for signs of fluid overload as well, like edema, especially peripheral or pulmonary, and then weight gain, elevate blood pressure, crackles or lung sound. So we want to auscultate for any crackles when we are listening to lung sounds. So we want to monitor for dehydration, like hypotension I mentioned, decreased urine output like dry mucous membrane also are indication of dehydration. And then daily weights, we want to do that as well to assess for fluid retention or even fluid loss as well. Intake and output, like strictly required to evaluate fluid balance is one of the way that we can monitor. We want to look for like electrolyte and metabolic monitoring, like we want to monitor these. So initially then we do like 2 times per week until the person is stable. We look at the sodium, the potassium, the magnesium, the calcium, and the phosphate. And then we want to do like some renal function like the BUN and creatinine. We want to do some liver function tests, as I mentioned before, the AST and the AST and the ALT. I want to do the bilirubin as well as the ALP. Then triglyceride level, especially in if lipids are infused in the TPN. And then we want to watch for and which is like always going to be mentioned when it comes to hyper and hypoglycemia, and then hypertriglyceride level because of lipid and liver enzyme as well. Always monitor the central line for associated bloodborne infection. The class B is a major risk. A monitor of a fever, redness, swelling, or discharge at the catheter site. Elevate white blood cell count is also could be an indication of infection. So perform routine sterile central line care when we're doing nursing action, and then report any culture and any suspicious signs immediately, and then follow infection prevention protocol to prevent introducing any infection to our patient. Refeeding syndrome surveillance occur when feeding is initiated in several malnourished patients, leading to dangerous electrolyte shift. So we want to initiate this in when feeding is initiated, most especially in patients who are like severely malnourished. And they want to monitor closely within the first 72 hours for hypophosphatemia. This is the hallmark. And then hypokalemia, hypomagnesia, magnesemia, fluid overload, cardiac arrhythmia, and confusion. So nursing action, start TPN slowly and cautiously in high-risk patient, and then supplement electrolyte before and during initiation, and monitor cardiac function and electrolyte frequently. And I know I repeat this a lot, just ongoing reinforcement. So check TPN solution for correct formula, expiration date, color, and clarity. Infusion pump setting and accuracy. Tubing change is every 24 hours for the tubing change, and filter use is 0.2 micron for standard TPN, and then 1.2 micron if lipid are included. Always want to document the catheter site condition in each shift. You want to check the catheter site and document what the site looked like on each shift. So this overall monitoring TPN therapy must be thorough and consistent. Nurse must assess glucose level, fluid status, lab values, and signs of infection to prevent serious complication. And early detection and communication with the healthcare team are key to maintain patient safety and optimize nutritional outcome. So prevention of complication. Prevention of complication in total parenteral nutrition therapy is a life-saving intervention by carrying significant risk. Nurse and healthcare provider must use proactive strategies to prevent metabolic, mechanical, and infectious complication during therapy. Prevention of hypoglycemia occur if the TPN is stopped abruptly, so especially in patients on insulin or long-term TPN. So you want to taper off the TPN gradually over 1 to 2 hours before discontinuation. You want to monitor blood glucose closely, especially when you're weaning off the patient. And if TPN must be stopped suddenly, you want to administer 10% or 20% dextrose IV to prevent rebound hypoglycemia. Then we want to monitor for signs of hypoglycemia, like shakiness, sweating, confusion, dizziness. And then ensure TPN solution integrity. Always there are always a risk for contamination, so if you improperly prepare the TPN, this can cause infection and embolism. So you want to make sure you are using the proper strategy. Inspect the bag for cloudiness, separation, leak, or discoloration. Check for expiration date, labels for accuracy before administration, and then store TPN in refrigerator and bring it to room temperature before use. Never use expired or damaged bag. You also want to administer within 24 hours of hanging the TPN. So prevention of hypoglycemia, high dextrose content can cause elevated blood glucose level. You want to initiate TPN slowly, especially in critically ill or diabetic patient. Perform blood glucose monitoring every 4 to 6 hours, more frequently at initiation. Administer regular insulin in TPN or subcutaneously as prescribed. Adjust insulin dose as needed based on blood sugar trend. We want to also work to prevent metabolic acidosis, can result, and this can result from excessive glucose metabolism or inadequate bicarbonate precursors. So strategies is to monitor arterial blood gases or serum bicarbonate, adjust dextrose concentration as needed, ensure balanced electrolyte and acid-base profile in TPN formulation, collaborate with pharmacy to tailor TPN composition in acidotic patient. Tubing and filter management. So risk is infection, occlusion, embolism from poor tubing practice, and then the strategy is to use dedicated TPN line. Do not mix with other infusion. Change TPN tubing every 24 hours. Use inline filters I mentioned before, like the 0.2 micron for standard TPN and 1.2 micron for lipid containing TPN. Maintain aseptic technique and doing all TPN and dressing change. And then managing fluid shift and volume overload. So risk, TPN can cause fluid retention, edema, overload if not monitored. The strategy is to monitor daily weight, intake and output, and lung sound. Assess for signs of edema, hypertension, or dyspnea. Use fluid restricted formula if necessary. Adjust fluid rate based on renal and cardiac function when adjust the rate. So tip to prevent ear embolism, which can occur when ear enter the central venous catheter system. Some strategies: always prime the TPN tubing carefully to remove all ear before connection. Clamp the catheter port when not in use. Instruct patient to perform Valsalva maneuver or exhale during the line change if appropriate. Ensure secure catheter connection at all time. Position patient in Trendelenburg doing line insertion, removal if allowed. So doing the line insertion and doing the removal if this is allowed. So overall is effective prevention of total parental nutrition related to complication requires a team-based vigilant approach. Nurses are essential to ensuring safe practice through careful monitoring, proper handling of equipment, and timely response to early warning signs. Adhering to these strategies promote patient safety and optimal nutritional outcome. So TPN is a life-saving nutritional therapy for patients with impaired GI function. Effective use require multidisciplinary approach with careful patient selection, close monitoring of metabolic parameters, and vigilant nursing care to minimize complications and ensure safe and effective nutritional support. Best practice in nursing care for TPN client is preparation and administration. Is to verify TPN order, solution, expiration before administering. Use electronic pump for infusion for accurate rate control. Administer via central line. Maintain patency and integrity. Change tubing and dressing every 24 to 72 hours per your facility protocol. Use inline filter to prevent particulate contamination. For infection prevention, practice strict aseptic technique. Doing catheter care. Monitor the site for redness, swelling, or discharge. Educate the patient on hand hygiene and signs of infection. Report and document any signs of infection promptly. And then for metabolic monitoring, you want to monitor blood glucose level frequently. Manage hyper and hyperglycemia promptly. Watch for signs of refeeding syndrome. Initiating TPN cautiously in malnourished patient. Assess for fluid overload or dehydration through daily weight and iron O monitoring. And then for patient safety, never add medication directly into the TPN bag unless prepared by the pharmacy. Ensure TPN is delivered via a dedicated IV line, and taper TPN gradually to avoid hypoglycemia. You want to verify TPN solution clarity and appearance before hanging. And then patient and family education, you want to teach catheter care and infection prevention for home TPN. Instruct or recognizing signs of complication like fever, swelling, hypoglycemia. educate on glucose monitoring and management if needed. So definitely interdisciplinary collaboration is very important. You want to communicate regularly with the dietitian, the pharmacist, and the physician. Collaborate on TPN formula adjustment based on patient status. Participate in regular care planning and review. So overall, nursing care for TPN client require vigilance, precision, and education. By following evidence-based practice, nurse can minimize risk, detect complication early, and support patients through the critical nutritional therapy, ultimately improving overall outcome and quality of life. So next we have some NCLEX style question. Question 1, I believe I have 10 of them. Question 1, TPN indication, and which client is most likely to require total parenteral nutrition? We went over this. Is it client A with functional GI tract experiencing mild nausea? Client B with severe burn and a non-functional GI tract? A client recovering from laparoscopy, appendectomy? A client with mild anemia and oral intake? And the answer is B, client B, a client with severe burn and non-functional GI tract. TPN is indicated when the GI tract cannot absorb nutrients, such as in severe burn or GI rest situation. Then question 2, monitoring glucose. How often should a nurse check the blood glucose of a client receiving TPN? Is it once a week, once per day, every 8 hours, or once per shift? The correct answer is D, once per shift. Blood glucose should be monitored at least every shift because of TPN high glucose content and risk of hyperglycemia. And I just some notes for a client with severe burn indication for TPN. So why severe burn may require TPN? Severe burn inquiry causes a hypermetabolic and hypercatabolic state, right? So dramatically increasing the body nutritional need. Patients often have extensive tissue damages, leading to increased protein and calorie requirement for wound healing. So impaired gastrointestinal function due to stress, surgery, or ileus, which may limit enteral feeding. Fluid shift sometimes, and edema, complication, oral or enteral nutrition. So indication for TPN in severe burn patient, inability to meet nutritional need enterally. So GI tract non-functioning or contraindicated. So like ileus or severe vomiting. Enteral feeding not tolerated or insufficient to meet the calorie protein need. In severe burn, malnutrition or high nutritional demand. So burns covering more than 20% total body surface area, significantly increased metabolic demand. So failure to maintain or gain weight despite oral enteral feeding in these patients. And then prolonged NPO status when oral enteral nutrition is not possible for greater than 5 days. Severe gut injury or surgery. So just a benefit of why TPN in severe burn, support wound healing by supplying adequate calorie and protein, help maintain lean body mass and immune function, prevent catabolism and muscle wasting, and can be carefully adjusted to meet changing metabolic need. So some indication as to why burn. And the next question is preventing rebound hyperglycemia. What should a nurse do to prevent rebound hyperglycemia when discontinuing TPN? Are we going to stop the infusion immediately, flush the line with normal saline? Are we going to titrate the TPN down slowly, administer an insulin bolus? So the correct answer is C. We know we're going to titrate the TPN down slowly, and the rationale is gradual withdrawal helps prevent rebound hyperglycemia and common complication when high glucose infusion stop abruptly. So question 4, recognizing refeeding syndrome. Which assessment finding may indicate the development of refeeding syndrome during the first 24-48 hours of TPN therapy. It says, which assessment find? Is it hypertension? Is it lethargy and confusion? Is it jaundice, diarrhea? So we know the answer is B. Lethargy and confusion is the answer. And rationale: symptoms of refeeding syndrome include bradypnea, weakness, lethargy, and confusion due to electrolyte shift. And if you want me to discuss refeeding syndrome during TPN, refeeding syndrome is a potential life-threatening metabolic complication that can occur when nutrition, particularly carbohydrate, is introduced too quickly to a malnourished or starved patient, including those receiving total parenteral nutrition. So what happened in refeeding syndrome? After prolonged starvation or severe malnutrition, the body metabolism adapts to a low energy state. When feeding resumes, especially with high carbohydrate loads from TPN, insulin secretion increased to manage the glucose. This caused a rapid shift of the electrolyte like phosphate, potassium, and magnesium, and then water from the bloodstream into the cells. So the rapid shift of electrolyte and water from the blood water from the blood goes into the cells. This shift leads to a dangerously low blood level, like hypophosphatemia, hypokalemia, and hypomagnesium. And then and the low blood level can cause fluid imbalance. So the hypophosphatemia is a hallmark for refeeding syndrome. So question 5, nursing action for interrupted TPN. If a client's TPN infusion is accidentally interrupted, what should the nurse do? Should she flush the line with heparin, administer 0.9% sodium chloride, administer 10% dextrose solution, restart the TPN at full rate? We know the correct answer is C. We're going to administer 10% dextrose solution, and I know we read 10 or 20%. 10%. Okay, we see 10% more. So that dextrose 10% prevent hypoglycemia when TPN is interrupted unexpectedly. And then question 6, identify malnutrition. Which lab value is the most sensitive indicator of a protein malnutrition? Is it immunoglobulin? Is it cholesterol, prealbumin, and white blood cell count? Correct answer is C, prealbumin or albumin. So prealbumin is a sensitive marker for acute changes in protein status and nutritional deficiency. So question 7, prevent infection. Which nursing intervention helps prevent infection in a client receiving TPN? Changing the tubing every 48 hours, using sterile glove for dressing changes, flushing the TPN line with heparin, using lower lock connector and occlusive dressing. The correct answer is D, using a lower lock connector and occlusive dressing. Rationale: these prevent ear entry and reduce the risk of contamination and ear embolism, lowering infection risk. Question 8, TPN system misuse. Which action is inappropriate when managing a TPN line? Using it to administer antibiotic, monitoring insertion site for signs of infection, and measuring glucose level every shift, verifying solution compatibility with other medications. So we know the answer that's inappropriate is A. We never put medication, so using it to administer antibiotic, we don't put medication in TPN. TPN line should not be used for medication unless confirmed compatibility. Inappropriate use increase the risk of complications. Question 9 and 10, complication prevention. What complication is most likely if TPN is infused too quickly? Is it bradycardia, osmotic diuresis, hypokalemia, dehydration? Correct answer is B, osmotic diuresis. We're going to see frequent urination. So rationale: rapid infusion of hyperosmolar TPN can cause fluid shift and osmotic diuresis, leading to dehydration and electrolytes imbalance. So, osmotic diuresis, in the definition, is a type of increased urination, diuresis, that occur when non-reabsorbable solution are present in the renal tubules, causing water to be retained in the urine. This happened because these solutions increase osmotic pressure in the kidney, preventing water from being reabsorbed into the bloodstream. So normally the kidney filter blood and reabsorb most of the water and solute. In osmotic diuresis, excess solute like glucose, mannitol, or urea, they remain in the renal tubules. These solutes draw water into the tubule via osmosis, and this leads to an increased urine output with high solute concentration, like for example polyuria. So clinical consequences is excessive urination, like I mentioned, polyuria, dehydration, and hypovolemia is what's going to happen because we're losing all this fluid. So then electrolytes imbalance can happen, like we lose sodium and potassium and magnesium, and then this then in turn, of course, we're going to see hypotension, and then a risk for acute kidney injury if volume is lost, if the volume loss is like really severe. So in patients receiving TPN, is especially those with hyperglycemia, osmotic diuresis may occur due to elevated serum glucose, leading to filtered, which is filtered by the kidney and excrete the reabsorption and glucose-urea. So we want to, of course, monitor urine output, serum glucose, and electrolyte level, monitor for signs of dehydration. So just to give you a little insight on osmotic diuresis, it's a loss of large volume of water and electrolytes in the urine due to the presence of unabsorbed solutes, like glucose, for example, in the renal tubule. It is common in uncontrolled diabetes and can occur in patients on TPN if blood glucose is not well controlled. So early recognition and management are key to preventing fluid and electrolyte imbalances. Next, we're going to go into intravenous therapy, fluids. We're going to look at the fluids. We're going to look at nursing consideration and any complications. So intravenous therapy fluid involve the administration of fluid, medication, or a nutrient directly into a vein. It is used for hydration, electrolyte balance, medication delivery, and blood transfusion. There are different types of IV fluid. Of course, we have the crystalloids, like the isotonic, hypotonic, and hypertonics, and we're going to go into those. And then we have the colloids. These contain large molecules like the albumin and the dextran to expand plasma volume. And we have, of course, nursing consideration for these is going to include to verify IV order, like the fluid type, the rate, and the volume. We want to monitor insertion site for infection or infiltration always. Check patient fluid balance, like the vital signs, lab results. We want to maintain aseptic technique during insertion and handling. We want to also educate the patient on what we're doing and signs and symptoms or if any complications. Typical complication we may see with IV therapy is going to be infiltration, phlebitis, infection like local or systemic infection. So we want to observe for redness, discharge, fever. Fluid overload also can happen, can cause hypertension, edema, pulmonary complication, and then of course ear embolism, like it's rare but serious and can cause chest pain, shortness of breath. So type of intravenous fluid, and the isotonic fluid, we have 0.9 sodium chloride and lactate ringers. So these are used for fluid resuscitation, maintenance in dehydration, and electrolyte replacement. They expand extracellular fluid without shifting fluid into or out of the cell. So it's like typical like blood is the same. So we have two drip set type, like macro drip and a micro drip. For macro drip, we use that for rapid fluid delivery used in adults or during an emergency. And then we also have micro drip for precise control used in pediatric or for slow, accurate infusion. Choice depends on the required flow rate and the precision. So some nursing consideration for us is to maintain sterile technique, to prevent infection, monitor flow rate and IV fluid bag to ensure accurate or correct volume delivery, and then regularly assess IV side for infiltration like swelling, coolness, or pallor, and then phlebitis like redness, warmth, pain, and along the vein side. So we want to always document any finding and intervention promptly if complication does arise when we are doing IV therapy or when we are given any type of intravenous fluid. So this is a type of intravenous fluid, like this is hypotonic solution. Example of an hypotonic solution is a 0.45% sodium chloride. So it's half normal, 0.45% sodium chloride. So initially isotonic become hypotonic in the body, like with dextrose. D5 to D5W is hypotonic, and then it becomes isotonic. So initially it's isotonic, then become hypotonic in the body. I want to make sure I said that right. So that's D5W. So initially it's isotonic, and then it becomes hypotonic in the body. The purpose is to shift fluid into the cell. Is used for cellular dehydration, like diabetes, diabetic ketoacidosis. Can cause cellular swelling and hypotension. So you want to monitor very closely. IV set selection. As I mentioned before, you have two: the macro drip and the micro. So macro is like delivery of 10 to 20 gauge, used for like rapid infusion, and the micro is for delivery of like 60 to 20 drops per ml. So ideal for precise slow rates, example like pediatric and elderly. So for the macro drop, you want to use like the 10 to 20 drop per ml for rapid infusion, and then for the micro is 60 drops per ml. Always want to utilize sterile technique. This is essential during IV insertion and maintenance to prevent infection. And definitely always want to clean the port and wear glove and change dressing as per facility protocol. You always want to monitor the flow rate to ensure accurate delivery using drip control or infusion pump. And you want to also check the IV fluid levels and flow set regularly to avoid overload or under delivery. Always want to inspect the IV site and do an assessment for signs of infiltration like swelling, coolness, phlebitis, redness, warmth, and pain. And you want to document and report any complication immediately. So like safe IV fluid administration require understanding of fluid types, selecting the correct drip set, using sterile technique, and monitoring flow rate, and assessing the site for early signs of complication. Types of intravenous fluid, like hypotonic solutions. So we have hypotonic. For hypotonic, we have 10 to 15% dextrose in water, or normal saline, and then 5% sodium bicarbonate. These are hypertonic solution, and they draw fluid out of the cells into the bloodstream. So these are the ones that shrink the cell. It is used in critical situation like hyponatremia, shock, or metabolic acidosis for sodium bicarbonate. So some caution: risk of fluid overload, cellular dehydration, because they are going to draw the fluid out of the cell, and then vein irritation, so monitor closely. So for macro drop, we have 10 to 20 drops per ml for rapid or large volume infusion, and of course for micro drop is 60 drops per ml for slow, precise delivery. So when used in accuracy and more essential, you want to do the micro drop, which is 60 drops per ml. Sterile technique is to always prevent infection during IV insertion and fluid administration. Always follow proper hand hygiene and glove use and proper disinfection protocol. You want to monitor flow rate, use infusion pump and manual drip count to ensure correct flow rate and volume delivery. Check frequently, especially with hypertonic solution due to their potent effect. Do a site inspection regularly for signs of infiltration such as swelling, coolness, and leaking. And phlebitis, you're going to see red and warmth and pain along the vein. So you definitely want to act immediately to prevent tissue damage or infection. Hypertonic IV solutions are potent and require careful monitoring. Use appropriate drip set. Maintain sterile technique, monitor flow rate, and assess IV site frequently to ensure safe and effective IV therapy. So here we have peripheral IV placement and consideration. So age-dependent IV site selection. So in a neonate or infant, common site is scalp, vein, dorsum of the hand or foot. Use small vein and minimal restraints. In children, sites are the hand, forearm, foot, if non-ambulatory. Avoid joints and dominant hand if possible. And then in adult, preferred site is forearm, dorsum of the hand. Avoid site near joint, valves, or previously compromised vein. And then the elderly, fragile vein, select a straight, visible vein. Avoid vein that roll or are near areas of flexion. So some common site and type of gauge used are like the 24 gauge. You want to use those in infants, in the elderly, and small vein people. This helps minimize trauma, and it also provide a slow flow. And then in the pediatrics, you want to use a 22 gauge in pediatric adult with small vein. Common for meds and this is common for meds and fluid. And then the 20 gauge is routine for adult use. It's compatible with most IV therapies, the 20 gauge. And then of course we know 18 gauge, like in surgery and blood transfusion. This is like rapid fluid as well. So these are like larger bore for volume resuscitation. We use 18 gauge. And 16 to 14 gauge, like in trauma and emergency. So it's very rapid infusion. This is basically used in like critical care. So short peripheral catheters are more commonly used, like 3.4 to 1.25 inches long. They use smallest gauge and suitable for therapy to minimize vein trauma. So we like short term. So some nursing consideration is assessment. Choose the best vein based on condition, therapy, and duration. Always use aseptic technique by performing hand hygiene, wear gloves, and disinfect the site. Always provide patient education, explain the procedure and the purpose. This will help to reduce their anxiety. And use transparency dressing to allow visualization, tape or secure to avoid dislodgement. You want to document, record the site, the gauge, insertion time, patient tolerance, and any complication. And then just overall, preferred IV placement require gauge, appropriate site selection, appropriate catheter site, and adherence to sterile technique. And then ongoing site monitoring and patient comfort are essential for safe and effective therapy. Common complication of IV therapy and nursing care includes circulatory overload, occur when too much fluid is infused too quickly, overwhelming the circulatory system. Some signs and symptoms that we may see is hypertension, dyspnea or shortness of breath, crackles in the lungs, neck vein distension, edema, restlessness, and anxiety. Some nursing care for this is to slow or stop the IV infusion immediately. You want to elevate the head of the bed to ease breathing. We also want to administer oxygen if it's needed. Notify the healthcare provider. Monitor vital signs and lung sounds frequently and document finding and any intervention that is taken at that point. You want to use infusion pump and adhere to prescribed flow rate to prevent reoccurrence. In infiltration, this is leakage of IV fluid into the surrounding tissue instead of the vein. And the signs and symptoms that we're going to see is swelling at or near the IV site, coolness to touch in infiltration. We're going to see pain or discomfort, pale or taut skin, slowed or stop the IV flow is what we want to do. And the nursing care is stop the IV infusion immediately, remove the IV catheter, elevate the affected limb, apply a warm or cool compress depending on the fluid infiltrated, and then document the incident. We want to also restart the IV site for we want to restart the IV in another location using a different vein and monitor the site for tissue damage. In phlebitis, this is inflammation of the vein caused by mechanical, chemical, or bacterial infection. You're going to see redness along the vein. You're going to see warm and tenderness at the site, swelling. You're going to see palpable card, like a hard vein. What we do is stop the infusion and remove the IV catheter. We apply warm compress to reduce discomfort and assess the extent of the inflammation. We also want to notify the provider if it's severe and document and monitor for worsening or signs of infection. We want to use a new vein for reinsertion, preferably on the opposite extremity. In phlebitis complicated by blood clot in the vein. So this is so signs and symptoms is similar to phlebitis. So this is thrombophlebitis, by the way. I think I said phlebitis. So this is phlebitis complicated by blood clot in the vein, and it's similar to phlebitis. It's redness and swelling and warmth, pain along the vein as well. So we want to slow or stop the infusion. And then you might even have some possible fever with thrombophlebitis. So some nursing consideration, want to stop the IV and remove the catheter. We want to apply a warm, moist compress to ensure circulation and notify the healthcare provider. Sometimes anticoagulation may be needed. So avoid massaging the site because of risk of embolism. We don't want to massage the site at all. We want to monitor for signs of systemic involvement like embolism, of course. And then if we're going to restart the IV, we want to use a different site, not the same site. So if we see hematoma, which is blood collection in the tissue caused by vessel wall rupture during IV insertion or removal, we want to, things what we're going to see is bruising or discoloration, swelling, pain or tenderness around the site. So we want to remove the IV catheter, apply direct pressure until bleeding stops. We want to apply a cool compress to reduce swelling and bruising. We want to elevate the limb to reduce discomfort, document the incident, and choose a different vein for reinsertion. So in situation with clotting obstruction, this is blockage of the IV catheter due to blood clot or precipitate medication. We might see sluggish or stop IV flow. We might see resistant when flushing, pain or swelling at the site. So like if you see resistant when you're flushing, don't want to force it because this might be like clotting or that's obstructing the flushing. This can cause pain and swelling at the site as well. So of course we do not want to flush the catheter. We want to disconnect the IV if patency cannot be restored, and we want to replace the IV line in a new site, and then prevent regular flushing. It can be prevented by regular flushing the IV line. So if we regular flush the IV line, we can prevent this as per protocol and avoid incompatibility like drug mixture during the IV line. This can prevent these things. So use closed IV system and maintain continuous infusion when necessary. central venous access device. So these are our catheter inserted into a large central vein like the subclavicle, jugular, femoral, or sometimes this is a via peripheral access, of course, for long-term or complex IV therapy. Typically you see these for long-term or complex IV therapy. So PICC line or a long flexible catheter is inserted through the peripheral vein, usually in the upper arm, and then it's advanced to the superior vena cava. So it's used for long-term IV antibiotics like even chemotherapy, TPN as I mentioned before, or frequent blood draws. You can use it for that too. Clarification: insertion usually requires specialized training or certification. Like you might have a PICC certified RN or vascular access team that can insert these things. Maintenance and dressing change can be done by the RN under hospital protocol. We want to use sterile technique for dressing change, and it's typically every 7 days if it's soil. So every 7 days or once a week, or if it's soil, for dressing change. You want to flush with saline and possible heparin. So to maintain patency. Assess for signs of infection, thrombosis, or migration of the catheter, and then secure with stabilization device or sterile dressing. You never want to take BP or venipuncture on the arm with a PICC line. And then we have also the TCVCs, that's a tunnel catheter, venous catheter, tunnel central venous catheter, and these are inserted into a central vein, usually the subclavicular or jugular, and tunnel under the skin before entering the vein. And these are like the Ickman or the Bruvac and Grosson catheters. And these are also used for long-term therapy like chemotherapy, dialysis, TPN. Those are some indication. So surgically implanted, it has a cuff that promotes tissue ingrowth to secure catheter and prevent infection. So nursing maintenance is sterile dressing change weekly or as needed, regular flush per protocol, monitor for infection, dislodge, and patency. Educate the patient on home care and signs of complication. And then the next one we have is the implanted port or the portacat. These are the VADs. These are like a small port implanted under the skin, usually at the chest area. It's attached to a catheter that enters the central vein. As I mentioned before, example like a portacat or Mediport. Is used intermittent long-term therapy, like example chemotherapy, is ideal for patients requiring long-term but frequent access. So we want to assess using a non-core like a Uber needle. Once access require dressing and flushing per protocol, usually weekly. When not in use, flush every 4 to 6 weeks to maintain patency. Monitor for infection or malfunction. General nursing consideration for all CVADs or a sterile technique is monitor for all handling. Some mandatory for her handling and dressing change, you all want to use sterile technique. And of course, daily assessment of the insertion site for redness, swelling, discharge, or pain, and monitor for complication like infection, local or bloodstream, catheter occlusion, hair embolism, and thrombosis. We definitely want to flush regularly using saline or heparin, and label lumen clearly if multiple ports are available for like blood draws or meds. And then do some patient education on care, activity limitation, and when to seek help for these catheters. So summary: maintain sterile technique, use aseptic technique during insertion, dressing change, and when accessing IV port. Always perform hand hygiene and wear gloves. We always do that. Disinfect hubs and ports before use to prevent infection. Early recognition of complication, regular access IV site for signs of off. You want to regularly assess the IV site for any infiltration, any phlebitis, infection, or circulatory overload. We want to also monitor our patient vital signs, fluid balance, and respond to their response to the therapy. And we want to report and document any adverse finding promptly to the healthcare provider. We want to also make sure we use proper selection of IV fluid, like choose fluid based on patient condition. If it's dehydration, electrolyte imbalance, want to utilize this prescribed therapy and maintain resuscitation, like for maintenance and resuscitation or medication. We want to understand the IV fluid type, like isotonic, like normal saline or lactate ringer for volume replacement, or hypotonic, like 0.445% normal saline for cellular hydration, or hypotonic, like dextrose 10 in water, 2% normal saline for fluid shift and emergency. And we also want to adhere to policies and protocol, follow institution guideline for IV insertion and maintenance. We want to do our flushing, dressing changes, and tubing replacement. And we also want to document and maintain our documentation, and always utilize infection control. Use infusion pump that is appropriate, drip sets and equipment according to standards to prevent any complication. We want to do effective therapy, as we know, require sterile technique. We want to be vigilant in our clinicals. We want to appropriate fluid selection and strict adherence to protocol. As we utilize these, help to ensure safe, accurate, and complication-free when administering IV therapy or treatment. Thank you. We made it to the end of this presentation. I appreciate your support.